Hello and welcome to Opioids and You, a training on opioid overdose prevention, recognition, and response. My name is Laura Morehouse with the Arizona Poison and Drug Information Center. Today I'll be taking you through an introductory training on opioids and naloxone, so no previous knowledge or experience is necessary to participate. The goal of this training is to teach you how to save a life. Before we begin, please make sure you have completed the pre-survey. Today's training is made possible by Mobilize AZ grant from Blue Cross Blue Shield of Arizona. Mobilize AZ is a public health initiative tackling critical health issues in Arizona, like the opioid epidemic, and working to prevent death from overdose. Here is a quick overview of the topics that we are going to be covering in the training today. We'll talk about opioids, stigma, signs and symptoms of opioid overdose, naloxone administration, naloxone distribution programs, connecting care, and finally, community resources. So let's begin by talking all about opioids. Opioids are a class of drugs commonly used to treat pain. Opioids work by binding to specific receptors in the brain, spinal cord, and GI tract. They diminish the body's perception of pain. However, opioids can also have an impact on other systems of the body, such as altering mood, slowing breathing, and causing constipation. There are legal or prescribed opioids. These include medicines prescribed by a doctor that are used to treat pain, such as morphine, codeine, methadone, oxycodone, hydrocodone, fentanyl, and more. Prescription opioids are typically prescribed by doctors for acute pain, like a broken bone, wisdom teeth removal, or post-surgery, or for chronic pain, like cancer, arthritis, and other long-term health conditions. Opioids also include illegal drugs such as heroin and illicit potent opioids such as fentanyl analogs like carfentanil. Illegal opioids are manufactured for use in the legal drug market. Illicitly manufactured fentanyl can be a standalone product, a low-cost additive to increase the potency of other illicit drugs such as heroin, or sold as counterfeit medicines such as oxycodone. Illegal opioids are also prescription opioids that are used by someone they weren't prescribed for. Illicit fentanyl and fentanyl-laced heroin have been linked to the rise in overdose fatalities nationwide. Dealers in search of something cheaper and stronger than heroin began mixing in illicit fentanyl. When mixed, manufacturers can get more profitability from a batch. Fentanyl is about 30 to 50 times more potent than heroin, and carfentanil, an elephant tranquilizer, is 100 times stronger than fentanyl and 10,000 times stronger than morphine. Here are some statistics from the past couple years that are depicting different stages of the opioid epidemic, beginning with prescription opioids. So what you're looking at is national drug overdose deaths involving prescription opioids, and you can see there has been sort of a steady decline since about 2011. This next graph is showing number of deaths involving heroin. So from 2011 was the rise in heroin, and you can see that continuing to increase through 2017. And lastly, we have the number of deaths involving other synthetic opioids, predominantly fentanyl. From 2016 to 2017, you can see there was a 10,000 number increase in deaths due to fentanyl. And throwing all of those graphs together, here are the three waves of the rise in opioid overdose deaths, beginning with the rise in prescription opioids, followed by the rise in heroin, and finally we are still in the rise in synthetic opioid overdose deaths. Here's some real-time opioid data from Arizona. You can see the data range there is from June 15th of 2017 to September 25th of 2020. In that time period, there were over 7,133 suspected opioid deaths and 51,387 suspected opioid overdoses, along with 2,228 instances of neonatal abstinence syndrome. You can go to the Arizona Department of Health Services website at adzdhs.gov/opioids to find more information about the real-time opioid data. So let's start by talking about some risk factors for overdose. The first one is mixing drugs. Drugs taken together can interact in ways that increase their overall effect. To prevent this, we want people to use one drug at a time and to try to avoid mixing pills and alcohol, or opioids and other drugs that are sedatives like benzodiazepines, such as Xanax. The second one is variations in purity, and this is talking about fentanyl. We want people to know which pills they're taking and to test for additives, such as fentanyl. To prevent this, we recommend using fentanyl test strips to test your drugs as needed. The third risk factor is tolerance changes. A period of abstinence can lower tolerance, which means that the body can only process a small amount of the drug. Tolerance can decrease rapidly when someone has taken a break from using a substance. You can think of that break as a jail sentence, detox, rehab, or perhaps they were in the hospital. To prevent overdosing because of tolerance changes, we recommend using less after any period of abstinence. You can always take more, but you can never take less. The next risk factor for overdose is using alone, and this one is pretty simple. There's no one there to help you if you overdose. We do recommend that people develop an overdose plan with friends or partners. Next is physical health. Age and physical health impact your body's ability to manage drugs. Anyone who uses opioids should be aware of increased overdose risk if they smoke or have asthma, sleep apnea, or respiratory illness, have kidney or liver disease, drink alcohol heavily, or are currently taking other drugs such as benzodiazepines or antidepressant medication. And lastly, we have changes in dose. We want people to be careful when switching from one type of opioid to another, especially with prescription opioids, which can be at different strength levels. So next we're going to talk about stigma. What is it and why does it matter for opioid use and opioid use disorder? So what is stigma? Stigma is powerful negative attitudes and beliefs often associated with substance misuse and substance use disorder. Stigma may stem from antiquated and inaccurate beliefs that addiction is a moral failing. Stigma can negatively affect self-esteem, damage relationships, and prevent people with substance use disorder from seeking treatment. In some cases, stigma may actually enhance or reinstate substance use disorder, a key part in the vicious cycle that drives people with an addiction to continue using drugs. Fighting stigma means fighting misconceptions about addiction, and we will talk about addiction shortly. So how does stigma affect people with substance use disorder? It can reduce willingness to seek treatment. These stigmatizing views lead others to feel pity, fear, anger, and a desire for social distance, and they can negatively influence healthcare provider perceptions, which can impact care. Stigma in healthcare can lead to delayed access to care, poor patient-provider relationships, negative outlooks about chances of recovery, and early termination of treatment. Stigma can also cause social segregation and diminish self-efficacy. Low self-esteem and self-efficacy can lead to the why try effect, meaning why should a person try to live and work independently if they are not valued as a human being? And then we'll talk a little bit about addiction. It's important to know that addiction is a complex brain disorder, and opioid use disorder is the medical term for addiction to opioids. All opioids are chemically related and, at any dose, carry some risk of addiction. Addiction is characterized by compulsive or difficult to control behaviors, despite harmful consequences and the desire to stop. The brain changes occur over time with substance use. These changes can impact physical and emotional well-being. There is no one single factor that can predict addiction. A combination of genetic, environmental, and developmental factors can influence risk. But what's most important to know is that addiction can be treated and people can successfully recover. So how do we battle stigma? One way is to use something called person-first language. Person-first language is a way of speaking and writing in which the person is always put before descriptor, identity, or diagnosis. The change shows that person has a problem rather than the person is the problem. Person-first language avoids illicit negative associations and individual blame. So instead of saying addict, junkie, or user, you would say person with a substance use disorder. Instead of saying former addict, you would say person who previously used drugs. Instead of clean, abstinence. And this is one really good example of using clinically accurate, non-stigmatizing terminology, the same way it would be used for other medical conditions. Instead of saying habit, say substance use disorder. Instead of relapse or slip, return to use. Instead of an addicted baby, you would say a substance-exposed baby. And instead of replacement or substitution therapy, medication-assisted treatment. So we'll move now on to talking about overdose recognition, including the signs and symptoms of an opioid overdose. So what happens when someone overdoses on an opioid? Overdose happens when a person takes more of a drug than their body can handle. Now, overdose can happen immediately or a few hours later. Opioids slow down the body, and basically your brain forgets to tell your lungs how to breathe. So the process of an opioid overdose is that the breathing slows and then stops. Lack of oxygen in the body may cause brain damage within 4 minutes. Then the heart stops and death. And so we are trying to intervene before the lack of oxygen causes brain damage when we are using naloxone. Now, why is it so important to have naloxone in the hands of as many people as possible? Because most people do overdose in the personal residence or their house. That's why it's so important to train as many people as we can to administer naloxone. So let's get into some of the signs and symptoms. Now, it's important to note that suspicion of overdose can be based on these presenting symptoms. They could be based on history of use, a report from bystanders, school nurse or staff prior knowledge of the person. Maybe you find nearby medication that suggests that the person was using opioids, or perhaps you find illicit drugs or drug paraphernalia on the scene. So all of those can lead to you suspecting an opioid overdose, but these signs and symptoms are a pretty good indicator when taken individually or all together. So the first one is no response to touch or sound. You may try to wake the person by calling their name or saying something they might not want to hear, like, I'm going to use naloxone. And we'll talk about the sternum rub, which is one way to determine if the person is responding to stimulation in a second. The second sign and symptom is slow breathing or not breathing. The person may also be snoring deeply or making gurgling or noisy sounds. Many people may mistake this for sleep when it is actually an overdose. And then third, blue or pale skin, lips, and nails, and this is showing oxygen deprivation in the body. The person may be very limp or they could be unconscious. They may have a very slow pulse or no pulse at all, and they could have something called pinpoint pupils, where the pupils become very small and constricted. Now again, we're looking at all of these symptoms together, along with things like past history, or perhaps you find some sort of paraphernalia nearby. Now, if someone is very high on opioids, but not necessarily experiencing an overdose, they may exhibit certain symptoms that are less severe than a person actually experiencing an overdose. So if a person seems too high or on the verge of an overdose, but still conscious, walk them around, keep them awake, and monitor their breathing. And do make sure to call 911 in case they do progress into an overdose. So what are the signs of being high? They might become very relaxed. Their speech is slowed or slurred, but they're still speaking. They're very sleepy looking. They are responsive to some sort of stimulation, either talking, shouting, or a sternum rub. They have a normal pulse and a normal skin tone. Again, signs of an overdose would be the paler gray, clammy skin, breathing that has slowed or stopped, that deep snoring, gurgling, or rattling sound. They're not responsive to any stimulation. They have a very slow or no pulse, and again, blue or gray lips and or fingertips. So now let's start our discussion about naloxone, also known as the opioid overdose antidote. So what is naloxone? Naloxone, also known by the brand name Narcan, is used to treat opioid overdoses in an emergency. And you'll see the Narcan nasal spray in the image on the right. Naloxone, very importantly, does not reverse overdoses due to other drugs. So it will not work on a cocaine overdose, if someone overdoses on methamphetamines, benzodiazepines, alcohol, or any other drug that is non-opioid. Very important, naloxone only works on opioids. There are 3 forms that we're going to talk about today. There's the nasal spray, aka Narcan, that's an intranasal form. There is the injection, typically just known by the generic name naloxone, that's our intramuscular form. And then there's an auto-injector underneath the brand name Evzio that I will demonstrate for you. However, know that the auto-injection form is quite expensive and very not well known. So typically you're going to be looking at the nasal spray or the injection form. Before talking about responding to emergency, we do want to mention scene safety and make sure that staying safe is your #1 priority. Do not enter any areas that appear unsafe for any reason. Stay aware of your surroundings at all times, and know that you'll generally be in a crouched or kneeling position when administering naloxone. If the scene or situation appears unsafe, always call 911 first. So here are the 4 steps to responding to an opioid overdose. We'll start by talking about the sternum rub, then discuss calling 911, how to administer naloxone if you do have it on hand, and fourth, and probably most importantly, rescue breathing. So let's start with the sternum rub. The sternum rub helps you evaluate whether someone is unconscious by stimulating with pain, but without actually hurting the person. In the past, you might have heard about throwing someone in a cold shower or using the knuckles on the lips to determine if there's any stimulation. Those can actually hurt the person, so we want to shift the idea to using the sternum rub, which again uses pain but is not actually causing harm. So if the person appears asleep or unconscious, try to wake them up. Again, you can gently shake their shoulder or say something that they you think they might not want to hear. And then what you're going to do is use the sternum rub to evaluate status. So you're going to, if you look at the video, you're going to take your fist and then turn the knuckles in. You're going to find the sternum, which is the breastbone in between the two ribs, and you're going to rub very firmly down on that bone, up and down. Again, pretty firmly. You can try this on yourself right now, and you'll see it's quite painful and can actually leave bruising if done too often. If there is no response to that sternum rub, you're going to treat this as an emergency and proceed to step 2, which is calling 911. Opioid overdoses are a medical emergency, and you should always call for help. Now, in some cases, there is a pretty legitimate fear of calling 911. So if calling 911 is not an option for you, make alternate plans if your rescue attempts are not working. Is there someone else nearby you can call? Could you provide rescue breathing naloxone and put the person in recovery position and then leave to alert someone else to call? Leave the person where they can be found if you have to leave the person, with doors unlocked and or open. Doing something is better than doing nothing. So if you are able to call 911, make sure to tell the dispatcher exactly where you are. Tell them what you see. You don't have to specifically say it's an opioid overdose, but give them the signs and symptoms that you recognized as potentially being an overdose. So they're not breathing, they're unconscious, they're turning blue. Those are all fine things to say. Tell the paramedics what you know about the drugs that the person may have been using. The paramedics just want to help. The person's not going to be in any danger from the paramedics. Do also let the paramedics know if you're planning to or have already used naloxone. There is something called the Good Samaritan Law here in Arizona. The intent of this law is to reduce the risk associated with calling 911 during an overdose emergency. So these are protections for a person who seeks medical assistance for a person experiencing an opioid overdose. The Good Samaritan Law protects against arrest, charge, prosecution, conviction, or forfeiture for drug paraphernalia possession, possession or use of controlled substances found on the scene. So please note that the Good Samaritan Law applies to the drug possession. If another crime is happening at the scene of the overdose, the person may be arrested for that crime. So let's get into the naloxone administration. We're going to start by talking about the intranasal form, which you will be receiving after completing this training. So how do you administer one dose? I'm going to be showing this on my video as well so that you can see it in person. So I'm going to pull out one dose, which is one nasal spray can. If you look at the video, I'm showing it right now. You're going to remove it from the packaging. So here's the packaging, front and back. You just peel off the back and remove the Narcan from that. Please make sure not to test the device. If you test the device, you'll be wasting one dose and you'll have to find another one. How you're going to administer, you're going to place your pointer finger and middle finger on the two little bridge tops on either side of the nozzle, and then you're going to place your thumb on the plunger. Again, make sure that you do not press down before you are ready to use. When you're ready to use, you're going to insert into one nostril. It doesn't matter which one, you only have to use one nostril. You don't have to do both. So you're going to place that nozzle 1/2 to 3/4 of the way into that nostril. So usually it's far enough where your fingers will hit the base of the nose, and that should be good. And then you're going to press the plunger completely down with your thumb. And that is one dose. All right. We're going to talk about what happens if that first dose doesn't work or what to do after the first dose. But I'm going to teach you the other forms first. And then we always get the question, when should you give naloxone? Again, if you suspect an opioid overdose and the patient has signs and symptoms of that opioid overdose. Only give naloxone if a patient is not responding to stimulation and an opioid overdose is suspected. There are other conditions that can mimic an opioid overdose, such as cardiac arrest, low blood sugar, head injury, and stroke. So, we'll talk about this a little later, but naloxone is safe for use in everyone. It will only affect people that have opioids in their system. So even if you're unsure, we're generally going to suggest that you use naloxone just in case. So let's move on to our intramuscular form. Again, this is a generic brand of naloxone. In the naloxone kit that's intramuscular, you're typically going to receive 1 to 3 vials of our naloxone, which I'm showing in the video, and an intramuscular syringe, which I have pulled out of the packaging here. You do want intramuscular syringe. Other syringes and needles will not be long enough to puncture through and reach the muscle correctly. So if you have your 1 dose of intramuscular naloxone, what you're going to do is pop off the orange top on top of the vial. So I'm showing this again in the video. And then you're going to drop 1 cc of naloxone into the syringe. Easiest way to do that for people that have difficulty using syringes, we do recommend to insert the needle into the vial. You either place it down on a flat surface and insert the needle going straight down, or you can lay the vial on its side on the flat surface and insert the needle this way. Now, once the needle is inside the syringe, we're going to want you to flip it up like a fancy pharmacist and drop all the contents into the syringe. And then you're going to push until it's right at the start of the needle, and you can tap it gently a couple times to get rid of air bubbles, but don't worry about that too much. Once you have the naloxone in the syringe, you're going to inject into a muscle. We recommend the thigh, the upper and outer quadrant of the butt, or the shoulder as being the best areas. You can inject through clothing if necessary. Typically, these intramuscular syringes are long enough and tough enough to pierce through clothing. Inject straight in to make sure you hit the muscle. Do not worry about hitting a vein. After using intramuscular naloxone, it's very important to not recap the syringe. Now, once the paramedics arrive, they may be able to dispose of the syringe in a sharps box when they arrive. Otherwise, sharps can be put in a strong plastic container, like a laundry detergent bottle. You're going to seal the container with tape, label "Do Not Recycle," and throw it in the trash. You can also check to see if your community or your county has a community sharps disposal program. Again, very important not to recap the syringe and make sure that you dispose of those sharps properly. And our third form of administering naloxone is, again, the auto injector. I have a trainer version of it here, so you'll see it. So what you're going to do to administer 1 dose, I'm going to read through the instructions first, and then I'll pull off the trainer version of this. You're going to pull the auto injector from the outer case, which is this black case right here. So you pull it up. You pull off the red safety guard. Do not touch the black base of the auto injector. That is where the needle is. You're going to place the black end of the auto injector against the outer thigh through clothing if necessary. Press firmly and hold in place for 5 seconds. The auto injector makes a click and a hiss when it is depressed again against the thigh. This is normal. It means the auto injector is working. After use, place the auto injector back into its outer case, but do not replace the red safety guard, and then dispose of the auto injector in a sharps container. Again, you can use something sturdy like a laundry detergent bottle to dispose of it at home, or find a sharps container in your community. So I'll hold up this trainer version up. So you remove the outer side.
This trainer contains no needle or drug.
Okay. So
if you are ready to use, pull off red safety guard.
So I pull off the red safety guard.
If not, to inject, place black end against outer thigh, then press firmly and hold in place for 5 seconds.
So example, if I was using this on the thigh,
to inject, place
I would pull
black
down.
end against outer thigh, then press firmly and hold. 5, 4, 3, 2, 1. Injection complete.
So
this trainer may be reused for training.
I'm gonna place that back in there. So it talks you through all of the instructions. Again, imagine I was using my outer thigh and not my arm. And remember that you are not going to be replacing the red safety guard. You're just gonna place it back in the container and then dispose of it the proper way. Since this is a trainer, I'm going to just put the red safety guard back on.
This trainer may be reused for training purposes. Replace the red.
But that's an example of how to use the auto injector. Very simple. Okay, so you've given the first dose. Now what do you do? We're going to talk about rescue breathing in a second, but you return to rescue breathing. The first dose should work within 3 to 5 minutes. If it doesn't work within 3 to 5 minutes, go ahead and give a second dose. Now, the time may be a little variable depending on which form of naloxone you use. Typically, the intranasal might take a little longer than intramuscular to come into effect. However, if neither works within 5 minutes, give that second dose if you have it on hand. Again, EMS needs to be called because of the risk that the person may have had fentanyl in their system and might need more naloxone than you have available. How do people usually come back? They return to spontaneous breathing. So if the person resumes breathing, if they weren't, that's how you know the naloxone's working. Again, if they do not start breathing, give a second dose. Now, the important thing to realize here is that Narcan can wear off within 30 to 90 minutes. Naloxone knocks the opioids off the receptors in the body, but the opioids are still in the body. Once naloxone/Narcan wears off, those opioids can reattach to the body and overdose can happen again. That's why it's so important to transfer that care to paramedics. Now, suspected fentanyl-involved overdoses should be treated according to these same standard protocols. However, because of the higher potency of fentanyl compared to that of heroin and some other prescription opioids, multiple doses of naloxone may be required to reverse that respiratory depression. Again, hopefully you're transferring care to paramedics so that they can give a larger dose of naloxone if needed. Now, after receiving naloxone, some people may experience mild withdrawal symptoms. Acute withdrawal symptoms only really occur in people who use opioids chronically, so over a long period of time, or have an opioid dependence. For example, for someone who is opioid naive, such as a child accidentally gaining access to one opioid pill and accidentally swallowing it, withdrawal won't occur. Withdrawal is not a reason to not give naloxone, but is a reason to make sure that you're careful to follow instructions and give the correct dose. Now, naloxone, again, can cause those acute withdrawal symptoms in people who have opioid dependence or using opioids over a long period of time. And those withdrawal symptoms have been described by some doctors as one of the worst things that you can ever go through in life. Just an awful experience is one of the quotes I've heard from doctors. So that includes body aches, sweating and shivering, agitation, nausea and vomiting, stomach cramping, diarrhea, increased heart rate, and for some people who perhaps have used for a very long time, seizures. Now, naloxone cuts off the high from opioids, so after a naloxone is administered, that person may want to use again. It's very important they do not use again for at least a couple of hours because they could overdose once naloxone wears off. People might also be very confused upon revival, and that can be improved by providing reassurance and explaining what's happening, telling them, you overdosed, I have used naloxone on you, the effects will wear off within about 30 to 90 minutes. So all of those could help someone who's very confused by what's happening. Being revived by naloxone can be a very traumatic experience, so do not expect the person to thank you or be very kind. Again, this is an awful experience, especially if they're experiencing those withdrawal symptoms. So just know that they might not thank you and they might not be very warm and welcoming towards you. Okay, so when you respond to the person, if they have a pulse but aren't breathing regularly or at all, the best thing you can do after giving Narcan is rescue breathing. And actually, even before giving Narcan, if the person isn't breathing, we want you to start with rescue breathing. Because again, the brain starts to die after a few minutes without oxygen, so rescue breathing can be the difference between life and death. So if you go to the person, they're not breathing, start by giving 2 even regular sized breaths and watching for the chest to rise. How do you do this? One hand is going to tilt the forehead back and plug the nose. The other hand is on the chin opening on the mouth. Create a seal with your mouth on their mouth. Again, give those 2 even regular sized breaths. If the chest doesn't rise, tilt the head back further. After those initial breaths, give 1 breath every 5 seconds when you're not actually administering the naloxone. CPR is not an effective response to an overdose unless there is no pulse. Opioid overdose results in respiratory arrest, so the breathing slows down and stops. If that respiratory arrest progresses to the heart stopping, then the person should get chest compressions if trained and rescue breathing. So again, rescue breathing, 1 breath every 5 seconds after those initial 2 breaths, and keep going until the person resumes breathing on their own. Again, spontaneous breathing is the normal reaction to naloxone. If the thought of putting your mouth on a stranger's mouth makes you uncomfortable, you can use a fabric barrier like the bottom of your t-shirt between your mouth and the other person's mouth. And there is also some other specialized equipment that is used to make sure that you don't have to actually put your lips on their lips if you are worried about that. Now, once you can confirm the person is breathing again, you want to place them in something called the recovery position, and there's 2 images there depicting that recovery position. The person should lay slightly on their side, body supported by a bent knee to prevent the person from rolling onto their stomach, with their face turned to the side. This will help keep their airway clear and prevent them from choking on their own vomit if they do begin to throw up. So again, slightly on the side, one knee bent, head tilted to the side. Now, there are a lot of myths surrounding naloxone, and we have them listed here. So I'm going to talk about the myth and then the actual reality or the truth related to naloxone. So the first one is that naloxone encourages drug use. We do hear this quite often. It's sending the wrong message. That's the second one. So the truth is that naloxone gives people a second chance at life. Patients can access additional treatment options if they're ready to. And then for the first one, naloxone also blocks the effects of opioids and can cause people to experience those withdrawal symptoms, which nobody wants. And then again, using naloxone sends the wrong message. The myth is that naloxone does not truly save lives and merely extends them until the next overdose. And the truth of the matter is that it's impossible to help someone who's already dead. For example, you can think about it like this. Putting naloxone in the home is very similar to placing a fire extinguisher in your house, in your kitchen. You don't put a fire extinguisher in your kitchen so you can be reckless and careless with the stove. Same holds true of naloxone, is there to save a life. The third myth is that naloxone could hurt someone not overdosing. And the truth is that naloxone is safe for everyone, and the benefits far outweigh any risks. The only effect of naloxone is to reverse the effects of opioids in the body. It is not possible for someone to overdose on naloxone. It can be safely administered to pregnant women, to children, to the elderly, and to animals. Again, the only effect will be on people who have opioids in their body. Then the last one is that overdose reversal requires a medical professional, and the truth is that with basic training such as this one, anyone can recognize and respond to an opioid overdose. Multiple studies have shown that with just basic training, users are fully capable of recognizing and responding. Now, there is some other important information about naloxone that we should discuss here. First, it is not possible to develop an immunity to naloxone. Again, someone that has used fentanyl might need more naloxone to recover. However, it's impossible to develop immunity to it. Naloxone does have an expiration date, but research has found that expired naloxone can still be effective even after several years. Current batches of Narcan and naloxone typically have a 2-year expiration date. However, there is a new batch of Narcan that's going to be on the market soon, and that will have an expiration date of 3 years. Best way to know is to check your box. So for the Narcan nasal spray, the expiration date is going to be in black right on the front of the box. And you'll find it on the kits that they give you for the injectable naloxone. So do check the expiration date just to be sure. If for some reason your naloxone has expired, some community organizations like Sonoran Prevention Works will accept the expired naloxone and give you a new kit. So do check that out, and we'll talk more about Sonoran Prevention Works very shortly. It's also true that naloxone is sensitive to light and heat. So when possible, protect from direct sunlight and extreme temperatures. We do recommend storing it in room temperature as possible. However, please note that research has found that even when placed in direct sunlight for over 30 days, naloxone only lost approximately 10% effectiveness. That means that if you have it stored in your car and it's been in there for a long time and you are responding to an overdose and this is the only thing you have, you can still use that naloxone. Just know that it might not work as much as it would have before. It will still help. It may still allow the person to breathe again, but it has lost some of its effectiveness. Again, you can turn in those expired naloxone kits into some community organizations, and they will give you a new kit in replacement. Another thing that I like to talk about with the intramuscular naloxone is that if someone has has problems with fine motor skills, or maybe they have arthritis in their hands or some other condition that makes it very difficult to put the syringe into the vial, what you can do is you can preload the syringe with the naloxone. So what you do is you would, on behalf of someone else, you would fill up the syringe with the naloxone from the vial, and then you can put the cap back onto the syringe, not used, so you haven't used the naloxone yet, but you can recap the syringe and then store it like this so that the person only has to take off the cap and inject in order to give naloxone. And it's going to be the same idea. You're going to want to store this outside of direct sunlight and extreme temperatures. A lot of naloxone kits will have a UV resistant bag that they come in, and there are ones that are large enough for syringes as well. So just check with the pharmacy when you go, or with the community organization where you get your naloxone from. Okay, so what are the laws around naloxone in Arizona? Just know that Arizona does have a standing order for naloxone. That means that any person can purchase naloxone from any pharmacy in Arizona without a prescription. Pharmacists can dispense any of the 3 naloxone products that we talked about, but you do want to call ahead to see if the individual pharmacy product is available and what that pharmacy prefers to have in stock. So it depends on the pharmacist and the pharmacy. Some might prefer to have Narcan, some might only have the naloxone intramuscular form. So do your research and call ahead. Most insurance plans cover naloxone. And then any person can administer naloxone to a person who is experiencing an opioid-related overdose. This is true for everyone. So teenagers can use naloxone, kids can use naloxone. Some people recommend training children on how to use naloxone, and there are training courses geared specifically towards children for using naloxone. So yes, everyone can carry it and everyone can use it when responding to someone who's experiencing an opioid overdose. Now, cost of naloxone can vary. Generic naloxone, so the intramuscular form, can cost between $20 to $40 per dose. The nasal spray can cost anywhere from $130 to $140 for a kit, and the auto-injector has a wholesale price of about $575 per kit. But there are many free naloxone distribution programs in Arizona that you can access as well. Sonoran Prevention Works, a statewide harm reduction organization here in Arizona, has a very useful map for finding naloxone near you. So go to www.spwaz.org/Arizona naloxone, and you can find naloxone near you. Sonoran Prevention Works also distributes naloxone, and so you can contact them as well to see if you can get a free kit. Now we're going to quickly talk about take-home naloxone programs, which are one of the top 3 strategies for addressing the opioid epidemic. So who should have naloxone on them? It's important to know that the CDC found back in 2015 that 83% of people who administer naloxone are people who use drugs. So patients who are candidates for naloxone include individuals with a history of overdose, with a history of substance use disorder, who are taking benzodiazepines with opioids, who are at risk for returning to a high dose to which they are no longer tolerant, and those who are taking higher dosages of opioids. Other people that should have naloxone, other than people who use drugs, are friends and family members, law enforcement, jails, prison and probation officers, treatment centers and sober living facilities, and homeless shelters and services, because they typically are interacting with people who use drugs. Again, take-home naloxone programs prevent deaths and are found to be very cost-effective. A wide variety of organizations participate in naloxone distribution efforts, such as syringe exchange programs, homeless shelters, emergency medical services, social service agencies. Libraries have been very important in distributing naloxone to those in need, healthcare providers, and substance use disorder treatment programs. So if you're interested in starting a naloxone program, they can be very easily integrated into programs that work with people at risk for overdose. So what are some of the things that you should consider? Make sure that you consult with staff, volunteers, if you have a board of directors, and the clients on what needs and opportunities exist at your agency for overdose prevention and naloxone distribution. Assess the availability of the staff willing to take a training and to actually provide naloxone. Consider liability and other legal issues related to doing such a program in your agency. Select and purchase which naloxone products you'll use, and have some sort of protocol for storing, using, and distributing that naloxone, and for training staff. And then train staff on how to recognize and respond to an opioid overdose and how to administer naloxone. Our next piece is connecting the care, so supporting people in pursuing recovery after you have given that naloxone. So after the overdose, this could be a good time to talk treatment and support options. But it's important to assess with an individual the continued risk for another overdose and use prevention messaging to help them avoid another one. So you could ask, what happened this time and how can we keep it from happening again? Then find out what kind of help, if any, the person desires. You do not want to coerce a person into treatment, though this situation may be a wake-up call. It's important to know that there are multiple barriers to people going into treatment for substance use. Sometimes people are just simply not interested, willing, or ready, or able to go to treatment. Some of those barriers include financial barriers, what's the cost of the program, waiting lists or availability to get into treatment programs, the stigma of getting treatment, untreated underlying mental health or trauma issues, which really make substance use treatment much more difficult, the acceptability of different treatment models, like medication-assisted treatments. The hours of operation of some of these programs can prevent people from accessing them, the staff on hand, and then the requirements for getting into those programs. All of these are barriers to getting treatment. It's important not to judge people for not going into treatment after an overdose. They simply might not be ready or able to. So what are some of the treatment options? Medication-assisted treatment is one of the most evidence-based approaches. This is treating opioid use disorder with FDA-approved medications, again, an evidence-based approach. It's the use of medications in combination with counseling and behavioral therapies to provide a whole patient approach to treatment of opioid use disorder. Typically, the medications used are methadone, buprenorphine, or naltrexone. Treatment can occur in several different places or settings depending on the medication used, the patient's situation, and other factors. Typically, there are 3 broad treatment settings, including outpatient, intensive outpatient or partial hospitalization, and residential addiction treatment or hospital settings. Now, other treatment aspects include patient participation. It's been found that participation in treatment and recovery improves outcomes. Counseling, which is an important part of treatment and usually required with all medications. The counseling can help patients address their personal, social, or other problems that may contribute to use. Patients are also encouraged to join support groups if it works for them. Examples of peer support groups could be things like Narcotics Anonymous. And then family and friend support. There's 2 sides to family and friend support. Families and friends play a key role in improving chances of long-lasting recovery, but on the flip side, places, persons, and events associated with addiction may contribute to a return to use. So it's important to just think about both of those sides. And our last slide is going to talk about a bunch of community resources that you can access here in Arizona. I'll go through them really quickly for you. There is the Arizona Opioid Assistance and Referral Line. It's a 24/7 line that helps with opioid questions, resources, and referrals. It is run by the Arizona Poison and Drug Information Center, and it is statewide. So you can call the number 888-688-4222 to get help from a specialized pharmacist. Now, some other resources, again, Sonora Prevention Works, services and support for people who use drugs in Arizona. Arizona 211 has a crisis response network that can be accessed by calling 211. Be Connected is for service members, veterans, families, and communities, and you can see the phone number and website address there. SAMHSA has a treatment locator, so you can find treatment for substance use disorder. There is something called the National Harm Reduction Coalition, which are advocates and allies for people who use drugs. And then Access has crisis services available on the webpage. It has a full list of 24/7 crisis lines, both nationwide and in Arizona. So thank you for joining me today and attending Opioids and You. If you do have questions, you can contact me by email at the address listed on this slide. Please be sure to complete the post survey after finishing this training. Thank you.